All right, we're going to talk about hypoglycemia in this lecture. I had a lot of fun putting this one together. A lot of people think hypoglycemia, especially like step one, step two, is simply just you took too much insulin, you took too much sulfonylureas, or you have an insulinoma. It's actually a lot more complicated than that. Obviously, those three are going to be the most probably like highly tested on step one, step two. But if we're trying to become expert clinicians, we have to consider other things that might be going on. And I'm going to give you a really nice and easy framework to kind of think through it. All right. So we're going to discuss the physiology of glucose handling will be really important for step one and also a review just to kind of understand what's going on. We'll discuss neuroglycopenia. So those are like going to be the symptoms a patient experiences when they're hypoglycemic. We'll do the framework for hypoglycemia. So we'll talk about presentations, pathophys, and management, and then we'll put it all together in a case. So this was the case I put on Instagram the other day. So if you didn't get a chance to answer it, we'll refresh you here. 67-year-old man with CAD and stage 3 chronic kidney disease is brought to the ED after being found unresponsive in the morning. He quickly improves after receiving IV dextrose. Labs drawn prior to treatment show his glucose was low, his insulin was elevated, his C-peptide is low, his proinsulin is low, his beta-hydroxybutyrate is low, sulfonylurea screen is negative, and then after IV glucagon, his glucose rises from 45 to 76. Which of the following is the most likely explanation for his hypoglycemia? Is this an insulinoma? Is this CKD-associated hypoglycemia? Was this exogenous insulin administration, or is this adrenal insufficiency? So take a minute, pause your screen, think through all the labs, think about his presentation, and come up with your answer. So this one is going to be exogenous insulin administration. Like at the surface level, I think the answer seems pretty obvious. We're going to kind of dissect insulin administration versus CKD because I did have a lot of people who pick CKD, and rightfully so. It's an intriguing answer option. But really what happens is when I give exogenous insulin, when a patient takes exogenous insulin, their insulin levels will be elevated. The thing is with exogenous insulin, it doesn't come with the C-peptide and proinsulin. We make it in a lab, and it's simply just the insulin. So when I give the patient exogenous insulin, it suppresses. It tells my body, hey, we've got enough insulin. It shuttles glucose in, and it shuts down the endogenous production of insulin. So if I tested the patient, though, their insulin level would be high, right? But because we have suppressed, we've done a negative feedback situation, endogenous insulin production is going to be low, and therefore C-peptide and proinsulin will also be low. All right. When I have a patient who has an insulinoma or sulfonylurea, okay, that is going to be endogenous production of insulin. Okay. Insulinoma is a tumor usually found in the pancreas that is going to secrete insulin. Okay, sulfonylurea, we're going to talk about the mechanism of sulfonylurea kind of when we get there, but it kind of stimulates the production of more insulin, more endogenous insulin. Okay, that's the mechanism of that drug, and we'll kind of talk about a little bit more in depth of that mechanism. Kind of, I've got it on a whole nother slide because I think it deserves that. But basically, insulinoma is secreting its own insulin. Sulfonylurea is causing the increased production of endogenous insulin. So when I make endogenous insulin, the insulin is obviously elevated, and whenever I make endogenous insulin, the C-peptide and the proinsulin will also be elevated, right? The C-peptide gets made with the insulin, and the proinsulin is obviously one of the pre-products of insulin, right? So those would both be elevated, and then obviously if this was sulfonylurea use, the sulfonylurea screen would be positive. So if we look in this patient, right, the insulin's elevated, but we see the C-peptide and the proinsulin are both low, and so we can pretty much rule out insulinoma, okay? This case doesn't really fit adrenal insufficiency. We don't see anything about orthostasis. We obviously do see the hypoglycemia, which can be seen. I don't give you anything about hyperpigmentation, which may not be seen in secondary adrenal insufficiency. We don't see anything about the patient taking steroids and abruptly stopping. Really, I don't tell you anything about eosinophils or electrolyte abnormalities, so it's likely not adrenal insufficiency. And then we'll kind of get into the CKD I've got on the next slide to how we break that down too. The other thing that we saw in this case is we see the beta-hydroxybutyrate is low, okay? So normally in fasting, it's above 2.7. In this case, it's 0.4. So when I see the beta hydroxybutyrate is low in a patient who has hypoglycemia, that tells me their insulin is high. Their insulin is being activated. So this would be an insulin dependent process, okay? Rather, because we're gonna break it down in a second to be insulin dependent or insulin independent, okay? And so really, when I think about the beta hydroxybutyrate is low, insulin's job is to shuttle glucose into my cells. It's to build, build, build. Really, when insulin becomes low, it stimulates lipolysis. I break down a bunch of free fatty acids. We take those free fatty acids, we shuttle them to the liver, we shuttle them to the kidney, and they undergo gluconeogenesis. And when gluconeogenesis runs out, then we stimulate ketogenesis, right? And we can use those free fatty acids as backbones to make ketones as well. But the fact is when insulin is high and insulin is the driving factor of my hypoglycemia, we don't need ketones, right? So the beta hydroxybutyrate will be low. All right. The other thing is when the glucose rises, practically usually the cutoff is above 25. So if the glucose level rises more than 25 milligrams per deciliter after giving glucagon, remember we're going to talk about glucagon, but glucagon stimulates gluconeogenesis. When that glucose level rises after administration of glucagon more than 25, it suggests preserved hepatic glycogen, and that really again rules out adrenal insufficiency. It rules out critical illness, and it also tells me the insulin is high because when insulin is high, we're storing, storing, storing. When insulin is low, we first undergo glycogenolysis. We do glycogenolysis in the first like 8 to 12 hours of fasting. That's breaking down my glycogen in my liver and my muscle to make it fuel, to make fuel, to make glucose. And then after usually 12 hours is kind of when the gluconeogenesis picks up. And then after about a day or two is kind of when ketogenesis picks up. Okay. So it's like the first 8 to 12 hours will be glycogenolysis. We cut the glycogen in the muscle and liver. 12 hours and beyond, we do gluconeogenesis until we're not able to really anymore. And then ketogenesis picks up usually around a day or two or three, kind of depends on the person. But really, so when we look at this, right, the beta hydroxybutyrate is low. So that tells me it's an insulin dependent process. We gave the IV glucagon, his glucose level rose by more than 25. So we can say it's probably not adrenal insufficiency, and it's probably a insulin dependent process. So then let's quickly look at CKD versus exogenous insulin use. So CKD is a very common cause of hypoglycemia, especially in a patient who has diabetes. Remember, diabetes is a pretty big risk factor for CKD. What happens is when the kidneys are damaged, the tubular systems are damaged in CKD, we have decreased renal clearance of insulin, C-peptide, and proinsulin. Remember, insulin is renally cleared, right? That's how we get rid of it. So what happens though is the patient in CKD, as long as they're getting their exogenous insulin, if they're taking it, and they're not administering more than they should, right? If we think about like someone who's like surreptitiously using more insulin than they should for a fictitious disorder or for some other reason, let's say they have their standard dose, they're taking their standard dose, but their kidneys aren't working as properly, we're just not going to renally excrete it as well, and that insulin can build up and then it's going to work better than it should, right? And it's going to shuttle more of that glucose into the cells. The thing though is C-peptide and proinsulin are also renally excreted. So what happens is we'll either see increased or inappropriately normal level of all three of those, right? Insulin, C-peptide, and proinsulin during hypoglycemia. Because normally during hypoglycemia, we should be shutting down the process of making insulin, right? I've talked about this in many lectures, and you're going to hear me on every single endocrine lecture I talk about, is if the insulin level is normal, or the C-peptide and proinsulin levels are normal when the patient is hypoglycemic, that is abnormally normal. In a patient with normal physiology, low blood glucose should be shutting down the release of insulin, okay? So in a patient who has CKD, the lack of renal clearance of all three of my products will lead to either a normal or elevated insulin, C-peptide, and proinsulin. My endogenous secretion is not going to be suppressed, okay? And then we have this risk because of the prolonged insulin half-life, right? This is not like an overdose, but it's because now the insulin is staying in my bloodstream longer than it should because the kidney clearance is low, right? The GFR is low. So this is shown in a lot of different guidelines and the evidence, right? The KDOQI state the reduced GFR leads to impaired insulin clearance, and then studies have shown higher C-peptide in moderate to severe CKD due to accumulation. Here are the studies if you want to go read them, right? I gave you 3 of them, so you can screenshot, throw them into Google. So again, in CKD, all right, the insulin is elevated or normal, the C-peptide is elevated or normal, the proinsulin is elevated or normal. If my patient is taking too much exogenous insulin, the insulin is going to be elevated, but remember that exogenous insulin does not come with C-peptide or proinsulin, so the C-peptide is low and the proinsulin are low due to negative feedback. My patient's taking in exogenous insulin. It's telling my pancreatic beta cells, hey, don't make any more insulin. We're good to go. So my C-peptide and proinsulin that are normally packaged with the regular insulin are going to be very low because we're not making any more of that endogenous insulin. All right, it's a tricky concept, right? So really play around, make sure this sticks in your head. And we'll break it down further as we go. So let's quickly talk about the physiology of glucose handling. So really, there's just 3 major organs we're going to talk about. We have the liver, which stores glucose as glycogen, right? And I could have also put in the muscles as well, right? Muscles store glycogen as well. And then we release glucose via glycogenolysis and gluconeogenesis. The reason I really didn't include muscles is, remember, the muscle tissue, the skeletal muscle, does not have that glucose 6-phosphatase enzyme. And glucose 6-phosphatase enzyme is a really key enzyme that converts glucose 6-phosphate into glucose, and then we can send out glucose into the bloodstream, right? So the fact that the muscle tissue does not have that glucose 6-phosphatase means that the glucose is always going to be attached to a phosphate group. And as long as that glucose is attached to that phosphate group, it has to stay within the cell. Think about that phosphate group as kind of like a handcuff that keeps the glucose in the cell. So that's why in the first step of glycolysis, we add a phosphate to it. We turn it into glucose 6-phosphate, and that keeps the glucose within the cell so we can go through the pathway. For the vice versa in gluconeogenesis, I need that G6-phosphatase to cut off that phosphate group so then we can release glucose. So again, the liver stores glucose as glycogen, and then it can release glucose via glycogenolysis and gluconeogenesis. The pancreas, we have obviously our insulin beta cells, super duper important here. Their job is to lower blood glucose, right? When insulin goes up, we're going to lower blood glucose. We're going to cause the uptake and storage of glucose and fat. The glucagon, right? The alpha cells here are going to be really important. So those are going to be their job, glucagon, is to raise blood glucose. It stimulates glycogenolysis and it stimulates gluconeogenesis. So again, insulin's being made from my beta cells, glucagon's being made from my alpha cells. Insulin lowers blood glucose, glucagon raises blood glucose, okay? The kidneys, obviously, we've talked about this really already, but they filter glucose at the glomerulus. They're also what's used to clear insulin. And then they reabsorb roughly 100% of your glucose via the SGL2 or the SGL2 transporters in the proximal tubule. If that threshold, if we get to a blood glucose level above 180, give or take, right? Now my SGL2 receptors, they start getting saturated, and any more glucose that makes it from the kidney, these receptors are already full, and so there's nothing to reabsorb. So normally the glucose is coming down and it will go through the receptor and will reabsorb it. When the glucose level is over like 180 or so, these receptors are already full, so the glucose keeps traveling down the kidney and we can start dumping glucose into the urine, okay? And so remember, like that's why we have, this would be a whole lecture on itself when we talk, we can talk a little bit more about HFrEF. I've already kind of talked about it, but we have drugs like SGL2 inhibitors like empagliflozin, canapagliflozin, and dapagliflozin that block these SGL2 inhibitors that are really, really good drugs for HFrEF and actually now HFpEF. And so we'll talk about the mechanism behind those when we do that lecture at some point. All right. The physiology of glucose handling, right? So we've kind of talked about this, but insulin, its job is to decrease glucose, right? It increases the uptake and storage. Glucagon's job, it increases the level of glucose. It causes increased hepatic release, right? So that's going to be glycogenolysis, gluconeogenesis. Cortisol makes us insulin resistant. It increases the blood glucose. It causes the increase in gluconeogenesis. So cortisol's job is to increase blood glucose. Epinephrine, hey, same thing. Increased blood glucose. It stimulates glycogenolysis and it decreases insulin release. Growth hormone, also going to increase blood glucose. It decreases glucose uptake and it increases gluconeogenesis. So again, insulin's our main player for decreasing blood glucose. And then we've got glucagon, cortisol, epinephrine, and growth hormone that all increase. Their job is to increase blood glucose. All right, so a little bit more on the glucose handling. In the fed state, we have just eaten a meal. Insulin's high. We take glucose and we uptake it into cells and we store it in the muscle, fat, and the liver. Okay. The fasting state, insulin's going to be low. Glucagon's going to be high now, right? Because I think about them as yin yang. When insulin's high, glucagon will be low. When glucagon's high, insulin will be low. So in the fasting state, insulin's low, glucagon's high, and the liver will maintain glucose via glycogenolysis and gluconeogenesis. In prolonged fasting state, remember I told you usually after 12 hours, we'll kick into gluconeogenesis. And then after a prolonged fast, we can stimulate ketogenesis, right? So that's taking those fat molecules and turning them into ketones. All right. So let's talk real quickly. What is the definition of hypoglycemia? It's usually a plasma glucose less than 70. Okay. When it becomes clinically significant, is usually below 54. Some literature might say 50. It's really give or take. So really, hypoglycemia is less than 70. Clinically significant is when we start to get around 55, 50-ish, when we'll start seeing some symptoms and we should be really worried. So when it's really severe, we'll see cognitive impairment. The reason for this is, right, my brain lives on glucose. If my glucose starts dipping and dipping and dipping, my brain is going to be deprived of the energy it needs. And you can see how that could lead to some severe cognitive impairments, right? So we think about Whipple's triad. Whipple's triad is something you want to just put into your memory bank, right? It's going to establish true hypoglycemia because a lot of patients can present with similar neuroglycopenic symptoms that I'm going to talk about on the next slide that can mimic hypoglycemia. But we want to make sure if we're going to work them up for hypoglycemia, we have to confirm this is true hypoglycemia. If it's not true hypoglycemia, we have to think elsewhere. So Whipple's triad, we have the symptoms of hypoglycemia, which we'll talk about in the next slide. They have an established low plasma glucose. And then when I give them glucose, their symptoms correct. So again, symptoms of hypoglycemia, which we'll talk about in a second, an actual level according like lab level of low blood glucose, and then the symptoms recover or they go away once we give them glucose. So again, kind of what's happening in this counter-regulatory response, when the glucose starts dipping between 65 and 70, insulin level in a normal physiology, insulin levels will decrease because again, hypoglycemia should decrease the production of insulin. Your body doesn't need to make any more insulin. So if we have a normal physiological process, that low blood glucose will inhibit the production of insulin from any more beta pancreatic cells. When we get to about 60, glucagon and epinephrine go high. And remember, those are going to stimulate glycogenolysis, and they're also going to help inhibit insulin, and that will help raise your blood sugar. When we get to less than like 55-ish, again, cortisol and growth hormone increase, right? And remember, we told you cortisol and growth hormone, they're going to help increase the level of glucose, okay? And then when we get to like kind of below 50, we'll start seeing the neurogenic and neuroglycopenic symptoms, okay? So let's talk a little bit about those because these are going to be symptoms you're going to want to recognize. So this usually occurs when we start getting around 50, 55-ish. It's due to insufficient glucose supply to the brain, right? So common symptoms, confusion, dizziness, visual disturbances like blurred vision, difficulty speaking, weakness or fatigue, seizures, loss of consciousness, or coma. This happens because the brain cannot store glucose and it relies on the constant supply. Hypoglycemia impairs my cortical and subcortical function, and the symptoms often precede or accompany my autonomic signs, right? A lot of these are my autonomic signs, okay? The clinical pearl is really what I want you to consider moving forward is when I see recurrent hypoglycemia in a patient, let's say the patient is a diabetic and they're taking too much insulin than they should, or for some reason the patient has recurrent episodes of hypoglycemia. Maybe they have newly diagnosed CKD and they haven't decreased their insulin dose. So patient was on X amount of insulin and they've just been taking it, They haven't realized their kidney function is slowly decreasing. They're still taking the same amount of insulin. Their insulin half-life is now increased, and the patient becomes hypoglycemic over and over and over again. What happens is when the patient is recurrently hypoglycemic, it blunts my autonomic warning signs. If you look at a lot of these signs, right, like the dizziness, confusion, the sympathetic overdrive, right, palpitations, tremor, coma, seizure, a lot of that is really going to be driven by my guy's cortisol and epinephrine, right? Like epinephrine is driving the sympathetic response, okay? So it's basically, I almost think about it as like a protective, it basically is a protective mechanism, right? I'm not necessarily sensing, my brain's not necessarily sensing the low levels of glucose, right? The brain has to, or what did I showed you here. My blood glucose has to be like less than 50 for me to start getting this confusion and the like seizures almost, or the coma. It's really like when I start dipping to like 60, like 55-ish, it's that epinephrine that's causing a lot of these like neurogenic symptoms, right? The tremor, palpitations, the sympathetic overdrive. And then once we dip into that 50, that's when we can start seeing kind of all of these, like the confusion, dizziness, visual disturbances, difficulty speaking, weakness or fatigue, seizures, things like that. So again, one more time, when the glucose starts dipping kind of below 70, it's that increased epinephrine and cortisol that cause the tremor, palpitations, sweating, diaphoresis, all those same signs that could show up in pheochromocytoma, hyperthyroidism, right? Kind of things like that, adrenergic overdrive. When that glucose dips below 50, now we're going to start seeing the neurogenic symptoms like confusion, dizziness, visual disturbances, difficulty speaking, weakness or fatigue, seizures, loss of consciousness, and even coma. One thing you want to be aware of, again, is the hypoglycemia awareness, is when we see this recurrent hypoglycemia, it's going to blunt my autonomic warning signs, right? It lowers my threshold at which epinephrine will be released. Your body gets used to being hypoglycemic, and it's like, hey, I don't need to release epinephrine until that blood glucose gets to be about 50, okay? Normally, epinephrine should be released at like 60. So now epinephrine is not being released until it's 50. Okay, now we're in trouble because normally it's those warning signs of the sweating, palpitation, tremor that triggers the patient to say, hey, I need to go eat some candy or I need to get some sugar in me really quick because I'm hypoglycemic. Now, all of a sudden, the patient's not going to start feeling that until 50. And look what happens at about 50 is we get all these neuroglycopenic symptoms, right? So the patient could lose consciousness. They could have seizures without even being aware that they were hypoglycemic. It gets even worse when the epinephrine signals dip down below 50 because now we're definitely probably going to have all these neuroglycopenic symptoms before the patient ever becomes aware that they're hypoglycemic. So again, it's classically in insulin-treated diabetics. They become unaware of their hypoglycemia because their recurrent hypoglycemia over and over and over again decreases the threshold at which my epinephrine is released. So normally epinephrine is released, hey, around 60. Because the body gets so used to this hypoglycemia, it's like, hey, we're not going to waste our epinephrine here. We're going to use it when we get to 50, okay? Or, hey, we've gotten so used to it being released at 50, let's release it when our blood glucose gets to 45. The problem is usually around a blood glucose of 50 is when we start getting the really severe neuroglycopenic symptoms, right? This is called hypoglycemia unawareness. All right. Let's keep it moving. So now that we've kind of gone into all the physiology, we can finally get into the pathophys and we'll break it down. There's not a whole lot of things here, so we'll get through this hopefully pretty quick. But how can we further break down hypoglycemia? I've already told you how we can break it down, so let's see if you remembered. So we can think about it as insulin dependent versus insulin independent, okay? So the causes of insulin independent, there's a lot of them, but really when I tell you them, they'll make a ton of sense to you. So it's not, I don't expect you to be able to rip off 9 right off the top of your head. I have gone over these schemas so many times, I can rip them off the top of my head. I think it's really important if you want to be an internal medicine doctor or maybe even an emergency medicine physician and you have to make really quick decisions. Maybe not as much as an internal med doctor where you're really trying to get to the root cause. An EM doctor would be really important to understand the signs and symptoms of hypoglycemia and be able to treat them. And then if you want to get to like a level where you truly understand like what's going on, then you can memorize these schemas, right? If you want to be an IM doctor, I would understand all the schemas I'm presenting to you, because one day it may really make a difference. So what are the causes of insulin independent hypoglycemia? Pause your screen and see what you can come up with, and then we'll go through. So here we go. For insulin independent hypoglycemia, again, there's 9 different causes really when we think about broad causes. Alcohol is a huge one. So the typical presentation is usually a fasting hypoglycemia. Maybe the patient will be intoxicated. Oftentimes, alcoholic ketoacidosis, which I'm going to do a whole lecture on ketoacidosis. There's 3 main types: alcoholic, starvation, and diabetic. So I'm going to save those for another day. But oftentimes, the patient with like alcoholic ketoacidosis that can stimulate hypoglycemia, the patient may no longer be intoxicated by the time they present with hypoglycemia because the process kind of takes a little bit. So they may not be intoxicated, and their urine ethanol screen may be normal depending on when the patient's presenting. So you have to have a strong clinical suspicion. Look in the patient's chart, talk to family members. Do they have a history of alcohol abuse? Really, the pathophys, it's a beautiful pathophys. I've got a slide coming up here where we'll kind of go over it. But alcohol inhibits gluconeogenesis. It does so by increasing the NADH. And NADH levels, when they get too high, they stop the production of gluconeogenesis. Okay, and I'll show you a picture coming up. To manage this, right, we obviously give IV dextrose. Super duper important for anyone who has alcoholic hypoglycemia. We need to give thiamine before glucose if we suspect a deficiency, right? Most patients with chronic alcoholism are thiamine deficient because they're not having a full like a full diet. And alcohol itself messes with thiamine metabolism and reabsorption. Thiamine is a super important cofactor for a lot of my different metabolic pathways. Super important for my brain. So the problem is when I give IV dextrose before thiamine and the patient is thiamine deficient, we're trying to run through all those pathways that use thiamine, and my dextrose isn't able, my glucose, right, which is dextrose, is not able to move through those pathways, and we get a buildup of really neurotoxic chemicals and metabolites, and it can cause further damage to the brain. Right. So really important. This is a classic step 2 question. Honestly, could even show up on step 1. If you suspect an alcoholic who has hypoglycemia, please, please, please give thiamine, IV thiamine, before we give dextrose. All right. Medications, there's a lot of different medications that can cause hypoglycemia. Usually think about it in hospitalized or elderly patients because elderly patients metabolize medications a lot slower than younger patients. Certain drugs I want you to be aware of are quinolones, pentamidine, ACE inhibitors, and beta blockers. I've seen ACE inhibitors and beta blockers tested quite frequently. They either increase insulin or they impair glucose production. Obviously, stop the offending drug, give them glucose support if needed. Sepsis, right? Sepsis always needs to be on your list. I've talked about sepsis a lot of times, so I'm not going to go into it here. I'll probably do a full lecture on septic shock because I've covered it in pieces. Let's put one together. But think about it in a critically ill patient with hypotension, right? This is a type of distributive shock where my systemic vascular resistance is very low. So my vessels get really leaky. So that's why we get hypotension and we'll see fever. In these patients, there's increased glucose utilization because the body's in overdrive. So my cells are going to use up all the free glucose. And we're also going to have impaired gluconeogenesis, making it even worse. We treat the infection. We give them glucose as needed. If it is a shock with adrenal crisis, obviously give steroids, right? Hydrocortisone is first line. Hydrocortisone has both glucocorticoid and mineralocorticoid properties. I've talked about that in other lectures too. Liver failure, right? This one should hopefully make sense to you, right? Think about cirrhosis signs. So we have palmar erythema, we have spider angiomas, we have gynecomastia, we have ascites, all things like that. The patient may have coagulopathy. I've done a whole lecture on liver versus DIC, so go watch that to understand why the patients might be coagulopathic. Ascites I talked about, right? The liver is my main bang for my buck, gluconeogenesis and glycogenolysis sectors, right? Remember, the muscle can store glycogen. The muscle can store glycogen, and then the kidneys can do gluconeogenesis. But really, it's the liver that does the vast majority of gluconeogenesis and glycogenolysis. So if I have liver failure, we obviously can't release glucose as well from glycogenolysis or gluconeogenesis. So manage the liver disease and give glucose support. Renal failure, we've already kind of talked about this. CKD signs, right? The patient may have a normocytic anemia secondary to a lack of erythropoietin from the peritubular fibroblasts that have gotten damaged. They may have a really reduced GFR. Remember, if the patient has, if they're old and they're weak and they're frail, creatinine is not a very good marker of kidney function. We can use something called cystatin C, which does not rely on your muscle mass. I'll talk about this when I do a lecture on CKD. We've already kind of talked about it, but in renal failure, there's reduced insulin clearance and C-peptide and proinsulin. And then, as I just mentioned, kind of another bang for its buck, the kidneys do play a small role in gluconeogenesis. So not only do I have reduced insulin clearance, but I'm also not making as much glucose via gluconeogenesis because the kidneys are damaged. The liver is the main player, but the kidneys play a small role. We'll do dialysis right if the patient has severe CKD and glucose monitoring. Malnutrition, this one should make sense too. Think about a patient with weight loss, frailty, vitamin deficiencies, where really just the patient has depleted substrates, right? They're malnourished. They don't have a lot to give to do gluconeogenesis. So their body can't make as much glucose via gluconeogenesis. Nutritional support, obviously be very, very careful of refeeding syndrome. Refeeding syndrome, we can talk about in a second. And then glucose monitoring. For adrenal insufficiency, we think about it in a patient with fatigue, hypotension, weight loss, hyperpigmentation. Obviously, the hyperpigmentation would not be there if the patient has secondary adrenal insufficiency. I talk about this in my Waterhouse-Friderichsen syndrome lecture. Go watch that. So here, when we have decreased cortisol, it leads to decreased gluconeogenesis and decreased glycogenolysis. Remember, I told you back at the beginning, cortisol increases gluconeogenesis, right? So if I have a patient with adrenal insufficiency, the lack of cortisol leads to a lack of gluconeogenesis and a lack of glycogenolysis. We give steroids, hydrocortisone, fludrocortisone if needed for primary adrenal insufficiency. That is my aldosterone. All right, glycogen storage disease. Think about fasting hypoglycemia in infants and children. There's a vast number of glycogen storage disease problems, right? Your von Gierk's disease, where it is the most common one. So be on the lookout for that. Or it's the definitely the most severe one. Your glycogen storage disease will be the enzyme defects, and you have impaired glycogen breakdown. And so what happens here is because they have a problem storing glycogen or breaking it down, we can't release glucose as well. So we get ourselves into a big problem. The patients will undergo fasting hypoglycemia because they don't have, within that first 8 to 12 hours, when we're solely relying on glycogenolysis, the patient doesn't have the ability to either store that glycogen or release it as well. So the patient isn't able to get that glucose spike, right, to fight them out of hypoglycemia. So in these patients, we have to do frequent feeding. Often cornstarch is very effective in these patients, and usually refer them to a specialist. Last but not least, we have non-islet cell tumors. So we think about a patient who has like a large tumor on a imaging of the MRI or a CT of the abdomen. We see weight loss and we see fasting hypoglycemia. These non-islet cell tumors usually have more or less the same mechanism. The tumor will secrete insulin growth factor 2, which acts just like insulin, but it's not insulin, right? So it's an insulin independent process, right? Because it's not actually insulin, it's insulin growth factor like 2, which acts like insulin. We're going to resect the tumor. We can use a glucose infusion, and we can give steroids for the insulin growth factor suppression. Okay. So with regards to this, the biochemical pattern of insulin-independent hypoglycemia other than CKD. So remember, CKD is one of my causes. CKD can get a little bit tricky when we think about it, and I already talked to you about how CKD, the labs may present, but really, when it's a biochemical pattern of insulin-independent hypoglycemia other than CKD, the labs are going to be more or less looking like this. The glucose is going to be low, okay, for whatever reason we just talked about for the 9. The insulin's going to be low, okay, because it's not an insulin-dependent process, and the hypoglycemia itself should be appropriately suppressing insulin because this is not an insulin-dependent process, okay? So your body is able to respond appropriately and suppress the insulin, but something else is causing this continual hypoglycemia. Again, because the insulin is low, we're not making endogenous insulin. Your C-peptide is low and your proinsulin is low, right? Endogenous insulin production is suppressed and there's no precursor production. The beta hydroxybutyrate can be high, okay? Ketogenesis is active. Insulin does the inhibition of beta hydroxybutyrate, the inhibition of ketogenesis. So if this is a hypoglycemic event secondary to something other than insulin, it's an insulin independent process. As long as the ketogenic pathway is working, your body should be able to produce enough beta hydroxybutyrate, right, to push you into ketogenesis. Okay. And then the glucagon response is usually minimal. That's because the liver glycogen is likely depleted or unavailable, right? Because the insulin is low, the body is probably trying to compensate with the glycogen, and we either can't in, say, glycogen storage disease, or we've run out of it, right? So if I get a patient who's got fasting hypoglycemia and it's an insulin independent cause, I'm going to do at some point after we stabilize the patient, right? If we're doing the full workup, we can do that IV glucagon and give it to them. Their glucose probably won't raise more than 25 because we've used up all their glycogen. There's nothing for them to sput out anymore. All right. So these really what I want you to get at is if it's an insulin independent cause, the insulin's going to be low, the C-peptide is going to be low, the proinsulin's going to be low. And then if you want to be a badass, right, you can understand even more why the beta hydroxybutyrate is high and why the glucagon is low. I really think understanding these boxes right here is the key to answering questions on step 1 and step 2. If you want to be an endocrinologist or you want to be a really, 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 really great internal med doc, you can try to understand the physiology and pathophys here. All right, let's keep it moving. So CKD-induced hypoglycemia, we've really already talked about it. So I'm not going to go into it more, but I just kind of wanted to show it more side by side one more time. Again, the insulin is normal or mildly elevated due to reduced renal clearance. The C-peptide is normal or mildly elevated. The proinsulin is normal or mildly elevated. The beta hydroxybutyrate is variable. The glucagon response often shows over 25 if my glycogen stores are intact. The pathophys we've already talked about. Really, I just want you to think about elevated insulin with preserved or elevated C-peptide and proinsulin. And again, this is considered an insulin independent because it does not stem from the excess insulin production, but rather decreased insulin clearance. So the patient is not taking in or making more insulin than usual. They're just not clearing it as well. So the half-life builds up. All right. I told you I would mention the ethanol pathway, right? So remember, ethanol gets broken down into acetaldehyde by alcohol dehydrogenase. That process makes NADH, and we make NADH further on as we're kind of breaking things down into beta hydroxybutyrate. When that NADH builds up, that actually inhibits gluconeogenesis, okay? So when we inhibit gluconeogenesis, we can't make more glucose. If you remember from my osmo gap lecture, this is the exact same pathway that methanol and ethylene glycol work through. So methanol gets broken down into formic acid by alcohol dehydrogenase, and that formic acid is really toxic to my eyes. And ethylene glycol gets broken down into oxalic acid, and oxalic acid is really toxic to my kidneys. We can give a drug called blank to inhibit this process. Fomepizole. So fomepizole or ethanol itself can actually inhibit this process, right? And decrease the production of formic acid and ethylene glycol. Go watch my Osmo Gap lecture and I explain all of that. All right, so those are my insulin independent causes. So how can we further, how can insulin dependent hypoglycemia be further broken down? We can break it down 2 ways. So I can think about insulin dependent hypoglycemia as the insulin being endogenous or the insulin being exogenous, okay? So exogenous insulin-induced hypoglycemia, there's only one thing, right? It's just the patient is taking too much exogenous insulin. So it typically occurs in patients with diabetes on insulin therapy or the patient with fictitious disorder. Fictitious disorder is a subject for another lecture that could be a whole lecture on its own when we compare fictitious versus like malingering. But fictitious disorder, the patient is going to cause some sort of harm to themselves in order to be put in the place of the patient who is like getting taken care of. They like being the patient who has to be cared upon, okay? So we'll see the sudden onset of symptoms of tremor, palpitation, diaphoresis, confusion, seizures, my autonomic symptoms, and then my neuroglycopenic symptoms, okay? It's often related to missed meals. If the patient's not eating, but they're still taking in their insulin, that's going to cause a problem because now the patient doesn't get the glucose from the meals. They're giving themselves too much insulin. They're exercising without adjustments, right? When we're exercising, we're using up our glucose, And if the patient is still giving themselves the same amount of insulin and they're exercising for a long time, we don't have enough free glucose substrates and the insulin is still working to shuttle glucose into cells. That's a recipe for disaster. And then hypoglycemic awareness, which we already talked about. Um, the pathophys, again, insulin is administered exogenously. It bypasses pancreatic regulation. It suppresses endogenous insulin, C-peptide, and proinsulin because our body senses, hey, we've got enough insulin. My beta cells don't need to make any more insulin, C-peptide, or proinsulin. It drives glucose into cells, decreasing the plasma glucose, and then it inhibits ketogenesis, right? So now there's no alternative brain fuel for the brain, right? The brain will rely on glucose or rely on ketones. If we have an insulin-dependent process, there's not going to be ketones and all that glucose is going to be driven into cells and we can get the neuroglycopenia. All right, your classic markers, we've kind of like hammered this home by now, but in exogenous, so right, we have, when we think about hypoglycemia, we think about insulin independent. We talked about those 9 things. We're now in insulin dependent. I take insulin dependent, I break it down into exogenous or endogenous. We're still on exogenous. So when my patient has insulin dependent exogenous hypoglycemia, the insulin's high, C-peptide's low, proinsulin's low, beta hydroxybutyrate is low, and the glucagon response is usually greater than 25 because insulin inhibits glycogenolysis. So when the patient is finally given IV glucagon and it outcompetes insulin, stimulates glycogenolysis, all their glycogen is just sitting there ready to be used because insulin has been inhibiting it. So, right, so their glucose should have a nice response to give an IV glucagon. So how do we manage this? Immediately, we're going to give IV dextrose or oral glucose. We're going to, if unconscious, we can give them IM, intramuscular glucagon, which should raise that blood glucose really quickly. We're going to review their insulin regimen, adjust the dose or timing, educate on meal insulin coordination, address renal function or drug interactions if we suspect that. To prevent recurrences, we can use continuous glucose monitoring and consider switching to basal analogs with lower hypoglycemic risk. So again, the insulin dose or like the insulin drugs could be a whole lecture on itself. That's not the point of today. But we kind of have 2 flavors of insulin, more or less. There's the basal that works slow and long, things like detamers and glargine that are usually used as bases. The patient usually takes them either before bed or in the morning, and they act like my baseline low and slow insulin. And then there's the bolus insulins, things like Aspart and Lispro that work now. The patient usually takes those 30 minutes before meals. So we can consider switching to more longer, slow-acting insulins if needed. All right. We've already talked about the pathophysiology of hypoglycemia unawareness. So I kind of just brought it up one more time just to make sure we hammer it home. But really, this is a condition in which patients do not experience the early autonomic warning signs of hypoglycemia, including the risk of, or increasing the risk of the severe neuroglycopenic events. So really, it's usually the early autonomic warning signs of sweating, tremor, diaphoresis that trigger the patient, hey, I need to eat some sort of glucose so I don't get these neuroglycopenic symptoms of confusion, dizziness, coma, seizure, and even potentially death, right? So what are the clinical consequences? The delayed recognition can lead to severe hypoglycemia. It can occur during sleep or exercise, and then it's common in long-standing type 1 diabetics who have had these recurrent episodes of hypoglycemia over their life. The management strategy, again, we relax the glycemic targets. We can let the patient get a little bit more hypoglycemic than we normally would like. We can avoid hypoglycemia for several weeks to reset the threshold. We can use continuous glucose monitoring and then some education. So again, I've kind of talked about this, but if you like it in table form, here you go. Take a screenshot, throw it into ChatGPT, do whatever you need with it. All right. So now to our last section, right? We've talked about insulin independent. We've talked about those 9 things. We've talked about insulin dependent. We've broken it down into exogenous, which is just insulin use, and now endogenous insulin dependent. There's 5 major things. So pause your screen and think about it. All right, so let's finish strong here. The 5 major things that can cause insulin-dependent hypoglycemia endogenously would be things like sulfonylureas or meglitinides, right? Meglitinides aren't really used as much anymore. Sulfonylureas still are. So these can be a diabetic patient on oral medications, right? That's classically how they present it in a vignette. They have recurrent fasting of postprandial hypoglycemia. The pathophys here, and I've got a slide on it coming up in a second, but the drug is going to stimulate endogenous insulin release. It increases insulin, C-peptide, and proinsulin because it stimulates endogenous insulin production. And whenever endogenous insulin is produced, so is C-peptide and so is proinsulin. To consider this, right, we stop the drug. We can consider octreotide, which will stop, it will kind of counteract insulin, and we can educate on med reconciliation. Really stopping the drug is going to be go-to. We have our good old friend insulinoma. Everyone knows insulinoma. So we have Whipple's triad. Remember, remind me one more time, what's Whipple's triad? So there's going to be symptoms of hypoglycemia. They're going to be an actual blood glucose that is low, right? So less than 70 is how we define hypoglycemia. And then it's going to have recovery of symptoms after we give them glucose. They're going to have fasting hypoglycemia. So that's like a hallmark of insulinoma, is because it can secrete insulin whenever. And so the patient can have fasting hypoglycemia. Normally, when the patient is fasting, their glucagon and epinephrine and cortisol should be high. Insulin should be low. All right. We could see the neuroglycopenic symptoms, and the patients are usually middle-aged, but they could honestly, you could get an insulinoma kind of really at any time. Again, we have an insulin-secreting tumor. The insulin-secreting tumor is going to increase insulin, C-peptide, and proinsulin because it's making endogenous insulin. All right. How do we deal with this? We do surgical resection. We can give diazoxide, which I'm going to talk about in a second because it's actually got the exact opposite mechanism of sulfonylureas. We can give octreotide, and we can localize the tumor with imaging and then cut it out. There's something called post-bariatric hyperglycemia or hypoglycemia. This usually occurs 1 to 3 hours post-meal. The patient's going to have a history of a Roux-en-Y, right, a gastric bypass, and they could have neuroglycopenia. The pathophys here is when the patient undergoes gastric bypass surgery. The travel pattern of the food through my system is a lot smaller, right? And so we're going to get an exaggerated GLP-1 and insulin response post-meal because the food is going to move through a lot quicker than normal. We're going to get a huge bolus of glucose, and in response, we're going to get a huge bolus of insulin and a huge response by GLP-1, which further causes insulin sensitivity. And that's going to cause a massive dumping of glucose into cells and cause really quick hypoglycemia, usually 1 to 3 hours post-meal. So like the difference here is a patient with post-bariatric hypoglycemia is really only going to get hypoglycemia postprandially, where someone with insulinoma can get hypoglycemia fasting because we can just secrete the insulin whenever. The problem with post-bariatric hypoglycemia, if we understand the pathophys, we can understand the history these patients are going to present with. It's because of this short transit time through the gut where we get this huge glucose bolus, a huge response by the pancreatic beta cells, and a massive driving of glucose into cells, right? So it's really only going to be postprandial hypoglycemia. So how do we deal with this? We use more low-carb, high-protein. That's going to kind of slow transit time. The high protein slows the transit time. The low carb is going to prevent that massive insulin spike. We're going to do frequent meals. We can do acarbose. So acarbose kind of decreases the reabsorption of glucose in my intestine. And then rarely we could consider partial pancreatectomy. That's going to be like last bet. Again, low carb, high protein, frequent meals, and acarbose are going to be mainstays. There's something called non-insulinoma pancreatogenous hypoglycemia. I love this disease. It's a really cool one to consider. It is recurrent postprandial hypoglycemia, and it often is after pancreatic surgery, but it doesn't have to be. But again, postprandial, okay? This looks a lot like insulinoma, except it's postprandial. The problem here is we see diffuse B-cell hyperplasia, and it leads to endogenous hyperinsulinism. So in insulinoma, it's an actual tumor secreting insulin whenever it wants. In NIPHS, it's this the beta cells have just gotten bigger and bigger and bigger. And again, they're still not secreting insulin at whenever they want. They're only secreting insulin after a meal. They're just secreting way too much of it because they're big old buff beta pancreatic cells, right? So treatment here, same as insulinoma, we can do surgery, right? Get rid of some of that hyperplasic tissue. We can use the diazoxide, which again, we'll talk about in a second, and we can consider dietary modifications. And my all-time favorite disease in this lecture is going to be autoimmune hypoglycemia. So we're going to see spontaneous hypoglycemia, and it's sometimes related to other autoimmune diseases. Whenever I'm considering autoimmune disease in a patient, I always ask about, do they have a history of autoimmune disease, or do family? Does anyone in the family, right, that can kind of key me in, because autoimmune diseases like to run together and they like to run in families. Basically, I've got a picture of this next, but they have anti-insulin or anti-insulin receptor antibodies that can cause insulin overactivity or receptor mimicry. And I'm going to show you the mechanism on the next slide. Like any autoimmune condition, right, we can consider steroids, immunosuppression, or dietary adjustments. All right, so again, the causes of insulin-dependent endogenous hypoglycemia, we've got secretagogues, so sulfonylureas are going to be the go-to, insulinoma, we've got post-bariatric hypoglycemia, NIPHS, and autoimmune hypoglycemia. Here is the mechanism, the proposed mechanism of autoimmune hypoglycemia. It's from this book, Endocrine Connect. The insulin here, so these are the insulin molecules. They get bound up by these autoantibodies. And insulin getting bound up by those autoantibodies, it can't work, right? So there's very few amounts of free insulin. So there's low free insulin, and initially it causes hyperglycemia. The problem is, though, is that all of a sudden the autoantibodies are like, yo, we're done with you, we're done with you, insulin. And all the autoantibodies they dissociate, and it just leads to a massive amount of free insulin that's going to drive all that glucose into the cell. So again, at first, all these autoantibodies will attack insulin, and they'll cause very low level of free insulin, and it will lead to hyperglycemia. But then at some random point, the autoantibodies just do an unregulated dissociation, leads to a massive amount of free insulin, and it's going to drive all my glucose into cells. Really cool disease to think through. To consider, right, insulinoma and NIPHS can look a lot alike, and they're hard to tell apart. This is more like advanced management for maybe like step 2, step 3 land. Here's where I learned all this from. But really, we do the same thing, right? Whipple's triad, symptoms of low, like we have our symptoms, we have the low glucose and relief with glucose. Really what we're going to do for insulinoma is we're going to do this 72-hour supervised fast, right? When we do this fast, we're going to see the glucose is low, usually less than 40, right? Because that insulin is going to be huge. The insulin is going to be high. The C-peptide is going to be high. The proinsulin is going to be high. Everything we've already talked about. The beta-hydroxybutyrate is going to be low because insulin inhibits ketogenesis, and the sulfonylurea screen will be negative. When I do all that, I'm like, this is weird. This is telling me the patient is making too much insulin endogenously, right? We've ruled out sulfonylureas, okay? And so now let's move forward. We'll do imaging, and we can see a discrete tumor on CT, MRI, or endoscopic ultrasound. It's got 80 to 100% sensitivity, right? So pretty good test. We can then try to localize the tumor. Again, the CT, MRI, the endoscopic ultrasound, and then we can do a GLP-1 receptor, PET or CT if needed to further localize. We can consider invasive testing like selective arterial calcium stimulation with hepatic venous sampling. This would be something done by an endocrinologist or interventional radiologist. It is too advanced for them to ever ask you on step 1, step 2, and honestly probably step 3. But this is just for fullness of the discussion. Histopathology, we'll see the benign insulin secreting tumor, and the key differential or the differentiator is we'll see this focal autonomous insulin secretion from a tumor. So again, 72-hour fast with elevated insulin, elevated C-peptide, elevated proinsulin, and low beta-hydroxybutyrate. We'll probably see the tumor on CT, MRI, or endoscopic ultrasound. We can further localize with GLP-1 receptor, PET or CT, and we can potentially consider selective arterial calcium stimulation. For NIPHS, remember this is most likely postprandial, not fasting. But there's really no specific gold standard. It's a diagnosis of inclusion. So I would do my insulinoma workup first. If I don't see anything on my CT, MRI, my endoscopic ultrasound, or my GLP-1 receptor, PET or CT, then I would consider NIPHS, right? So we're going to see an inappropriate elevated insulin, C-peptide, proinsulin. The insulin levels are typically lower than insulinoma. We'll do, again, like I told you, the imaging to exclude insulinoma. We're not going to see that mass on CT, MRI, or endoscopic ultrasound. Instead, we might just see slight hyperplasia of the pancreatic beta cells. We can then consider the selective arterial calcium stimulation, which will show diffuse and multifocal insulin response. We'll see if we did a biopsy, we'll see islet cell hyperplasia, but we won't see a tumor. So the differentiator here is we'll see diffuse beta cell hyperfunction without a tumor. All right. So again, 72-hour fast. The labs may show up very similarly. We probably will see a mass on insulinoma. We won't see a mass on NIPHS. Selective arterial calcium stimulation can help us tell the difference. And then actually doing a biopsy would give us a definitive diagnosis. All right. I promised you I would tell you the difference between diazoxide and sulfonylureas. So diazoxide and sulfonylureas actually have the exact opposite mechanism. So diazoxide is a potassium channel opener, and sulfonylurea are going to close the potassium channels, right? So the mechanism diazoxide, it opens the potassium channel. It causes hyperpolarization because potassium is going to leave my pancreatic beta cells. And when the cells are hyperpolarized, it decreases insulin release. The opposite is true for sulfonylureas. This is why patients take them when they have type 2 diabetes, is it closes the potassium channel. It keeps potassium inside the cell. It leads to depolarization and increased insulin release. All right. The increased insulin release will then obviously drive glucose into the cell. The effect, diazoxide suppresses insulin secretion. So now you can see why it might be effective for insulinoma. Sulfonylureas stimulate insulin secretion. Diazoxide, again, is used for endogenous hyperinsulinemic hypoglycemia like insulinoma. Sulfonylureas are used more for type 2 diabetes. Diazoxide will be used to treat hypoglycemia due to insulin excess, and sulfonylureas can cause hypoglycemia as a side effect. All right, one last time. Endogenous versus exogenous insulin-dependent hypoglycemia. Really, for both patients, we're going to see decreased blood glucose, obviously. We're going to see the insulin level is going to be high, right? Usually if it's exogenous insulin, it's going to be really high because the patient can take as much as they want. Endogenous, it depends on how much they're secreting. But here's where we see the difference, right? When it's exogenous insulin, there's going to be low levels of C-peptide and proinsulin, okay? That's because when the patient takes exogenous insulin, it feeds back and it tells the pancreatic beta cells, don't make any more C-peptide, don't make any more proinsulin, don't make any more insulin because I've got enough. Endogenous insulin, whenever I make endogenous insulin, we make it with C-peptide and proinsulin. So both of them are going to be elevated. When the patient takes exogenous insulin, okay, we don't make that with C-peptide and proinsulin. We just make it with the pure insulin. So that's why we see the difference here. That's why I highlighted them in red, because that's how I tell them apart. The beta hydroxybutyrate should be low for both, because insulin, regardless of where it comes from, inhibits ketogenesis. The glucose response to glucagon will be elevated for both because insulin inhibits glycogenolysis. So when at the time when I give glucagon, their glycogen should be really full and it should have a nice response. Again, interpretation, I see this as exogenous insulin use. When I see all this interpretation for these labs, I think about it more insulinoma, secretog, NIPHS, like I showed you here, post-bariatric hypoglycemia and autoimmune hypoglycemia. So let's finish real quick. Here's the full schema that you should know, right? Hypoglycemia, I break it down into insulin dependent, insulin independent. For insulin independence, we talked about alcohol, medication, sepsis, liver failure, renal failure, malnutrition, adrenal insufficiency, glycogen storage disease, and non-islet cell tumors. And then for insulin dependent, we have exogenous and endogenous. Exogenous, we can think about just insulin, and endogenous, we think about secretogs, insulinoma, post-bariatric hypoglycemia, NIPHS, and autoimmune hypoglycemia. Play around with this a lot. Think about the labs. This is like a really, it's a thinking man's game here because you really have to think about what are the levels of insulin, C-peptide, proinsulin, beta hydroxybutyrate, the glucagon, the glucose response after glucagon, and then think about which one you're dealing with. If you want to read more, here's a few more articles, and you have the ones I went in the slide, and then we will put it all together. So, a 48-year-old man is brought to the emergency department by the emergency medical services after being found confused and diaphoretic in a public park.